Correct.
Ma'am, we are on live, ma'am, and we are starting session, ma'am.
Okay, sir.
So very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. The topic for today's webinar is primary dysmenorrhea. I welcome all the participants. I request them to post their queries, if any, in the chat box, so that we can have a short QA session at the end of this presentation. Now it's time to introduce our invited speaker for the day, Dr. Victoria, ma'am. Madam has done her MBBS and DNP in OBG. Madam is currently the consultant OBGYN at Victoria Clinic, Kanjipuram, Tamil Nadu. Madam was the past president of IMA, Kanjipuram. With this short introduction, I welcome you, ma'am. I'm handing the session to you for your presentation, ma'am. Welcome, ma'am.
Thank you for the kind introduction, sir. Stalin, sir. Good evening, everybody. Am I audible?
Yes, ma'am, you're audible, ma'am. You can share your screen and start your presentation.
Good evening, everybody. Today, the topic, I thank the Shield Connect also for this webinar. As you all know, I think it's not, what is menstruation is not at all needed actually. So to be on the thing actually, let me talk about as a OB-GYN, I am going to talk about the primary dysmenorrhea. The topic is today's topic. So as you all know, menstruation is the early, every month shedding of the endometrium, that is the lining of the uterus. It is a menstruation is known in various terms according to the local areas, and like menses, menstrual period, or simply period. So this is a cycle of the reproductive system, and the body is prepared for ovulation, and it finally ends in the pregnancy. So as you all know, the menstrual cycle begins on the first day of the period. So the average cycle ranges from 28 to 30 days. Moreover, however, some of the cycles will be shorter, like less than 21 days or longer than 35 days, which is called as oligomenorrhea. So this is a chart which shows the different phases of the menstrual cycle, whereas first 1 to 5 days is the menstrual period. Then the fertile period comes, that is the follicular phase comes, early follicular and late follicular phase comes. And the middle of the menstrual cycle, there's the ovulation, that is the LS surge precedes the ovulation. Then it starts the early luteal phase and the late luteus phase. So it has a early fertile window. So, and it culminates in the starting of the menstruation. So as you the previous slide also shows the various phases of the menstrual cycle. Our menstrual cycles are controlled from the hypothalamus pituitary, so releasing the gonadotropins in the anterior pituitary, that is LH and FSH, which controls the menstrual cycle. The early phase of the menstrual cycle is controlled by the follicular stimulating hormone. The next phase is controlled by the luteinizing hormone, which has the secretory phase in this. So this menstrual cycle, as you all know, it is a timed cycle. It is like a circadian rhythm actually. So it has been cycled. This cycle has been influenced by various things like according to the body weight, the age. It differs actually. The cycle, as you age, the cycle differs actually. So after the ovulation of the follicle, there is a formation of the corpus luteum. Once the fertilization occurs, the corpus luteum turns into secretes the progesterone for the sustenance of the pregnancy. So this cycle is always regulated by the estrogen and progesterone. So early phase follicular phase is regulated by the estrogen, and when the fertilization occurs or ovulation occurs, the progesterone starts. The secretory phase starts. So after when the fertilization doesn't occur, the there is a decrease in the progesterone level, which where the menstruation starts. So let us coming to our topic. What is dysmenorrhea? It's a Greek term. So it is defined as a painful menstrual pain of uterine organ. It is the most commonest gynecological problem seen in the reproductive age women. So clinically, it refers to pain during the menstruation, severe enough to prevent the daily activities and quality of the life of a adolescent women. As I said, it is a Greek term. This means painful. Meno means monthly. Rheo means spring. So it is a painful uterine cramps, which occurs during the periods. So in primary dysmenorrhea, the pain starts during the period and it subsides at the end of the period. So in secondary dysmenorrhea, it can occur prior to the periods, like it can present as a premenstrual syndrome or after the periods also, because of the pathological causes pertaining to the genitourinary tract. So it is termed as secondary dysmenorrhea. The pain varies in such cases. So this slide also talks about dysmenorrhea. It's a period pain. The pain has a temporal origin. So it is predominantly in primary dysmenorrhea or any dysmenorrhea. It is localized to the lower abdomen pain, and it relates to the back and also to the legs, producing leg cramps. Usually in adolescent, it starts from the menarche. Usually it starts in the adolescent period. But in the early menarche, like that is puberty, during that time, most of the cycles are anovulatory. So the dysmenorrhea starts after 6 months or after 2 years of the menarche, puberty. Okay. So mostly because of the anovulation, there's no ovulation. So any pain, if the woman is having pain, that itself means they have a ovulatory cycle. So dysmenorrhea usually does not start in the adolescent period. It starts after 1 or 2 years of the starting of the menstruation. So this pain is always clear and predictable and a temporary pattern. I told you the pain just starts before or at the start of the menstruation, especially the primary dysmenorrhea. It may be severe enough, it may be on the first day or throughout the periods. These are additional symptoms. Many women suffer from associated symptoms like nausea, vomiting, diarrhea, like bowel movements disorders. They have mood changes, breast changes, like presence as a PMS also. That is a separate entity to be discussed actually. So they have breast engorgement because of the progesterone effect. Mood changes, I said that they'll have depression, irritation, all these things. Loss of libido also be there. So because of what are the impacts of dysmenorrhea? It causes absenteeism in the school, loss of working days, decrease the work efficiency, and decrease study. So there is a loss of insomnia, is there, physical activity is there, depressed. There is mood changes, I said. So it affects the quality of life and performance of the daily activities in a woman. So the rate of absenteeism in these women range from 34 to 50%, losing 1 to 2 working days per month. As we all know, even our workers also like we as a doctors, we see our paramedics taking a leave because of this dysmenorrhea. So that itself causing a loss of working days. So this amounts to an annual loss of approximately 600 million working hours, or up to $2 billion annually in US. We don't have a study in our Indian studies. So what is the prevalence of dysmenorrhea? It is between 45 to 90% of the menstruating women. So severe, but that is 25% of the women among this may have a severe primary dysmenorrhea. So such dysmenorrhea appears to be the most common gynecological practice, irrespective of the age and nationality. So now the topic about our webinar is only of primary dysmenorrhea. It is that is more common menstrual cramps without pathological causes. As I said, there should not be. So it is only a functional dysmenorrhea. There's no organic causes. If there are organic causes like fibroid, endometrial polyp, adenomyosis, or tube ovarian masses, anything, endometriosis. These are inflammatory disorders, PID, genitourinary infections. When the causes are there, it is termed as secondary dysmenorrhea. So the exact cause of the dysmenorrhea is not understood, but it is possibly include. There are a lot of multiple factors with unexplained explanations. One of the causes is a forceful excess or excessive uterine contractility. Usually, during the menstruation, the uterine normal pressure is minimal. That is about 10 millimeter of mercury. During the dysmenorrheic phase, there is the uterine pressure is elevated to around above 120 mm of mercury. So there is increased number of contractions, that is more than 10 per minute. It is a non-rhythmic uterine contractions in these women with pain. Another theory is excessive synthesis of prostaglandins. That is the thing we as a doctor, we use a lot of NSAIDs because anti-prostaglandin is used for this medication as a mode of treatment. Another theory is disturbance or any condition decreases the uterine flow. That also causes a hypoxia and aggravating the pain. So let us go because one established cause is the role of prostaglandins. They are lipid compounds seen as in the cell membranes. It is produced from the arachnoid axis. So it is the phospholipase A as activates it. So the various prostaglandins are secreted. Actually, the E2 is more acting on the E2 is more acting on the uterus. So there is excess prostaglandin secretion will cause abnormal or forceful uterine contractibility of the uterus. It causes abnormal narrowing of the blood vessels supplying the uterus because as the uterine musculature has three layers, the longitudinal musculature and then outer longitudinal in circular musculature. The intervening is the crisscross layer. So once the uterine contracts, the blood vessel supplying into the myometrium, it goes into a lying ligature. Like it produces a lying ligature. So that produces hypoxia of the myometrium, and also there is increased sensitivity of the nerve ending, all culminating in producing dysmenorrhea. So how to measure the period pain and other symptoms? It is a numeric rating system. Pain scale is there. System for pain rating. These are there is a international menstrual system questionnaire is available. So we can give it to our patients when they have suffer from moderate to severe dysmenorrhea. These are the questionnaires. It is rated as whether they have the symptoms. Never, rarely, sometimes, others, always. So we used the questionnaire should be provided to the women who suffering from dysmenorrhea and to be filled. So according to that, we can rate whether it is they have no pain, middle pain, mild pain, moderate or severe, very severe enough to produce abstinence or disturbing the life of the woman. So this is the chart. As I said, the primary dysmenorrhea chart. It is done. This study is conducted from in Indian female students. Data is collected from 1,000 healthy females around the 11 to 28 years of age. So this is a self-reporting questionnaire is given, and pain intensity assessed by using the numeric rating scale. So these are the associated symptoms also have been recorded in this scale. So it has been the pain has been divided into mild, moderate, severe, and very severe pain. And what are the factors which release also is being taken into account in this. Let us coming to the pathophysiology of dysmenorrhea. So as I said, one of the main theories is excess production of prostaglandin, which causes the forceful uterine contraction, resulting in hypoxia of the uterine muscle, and also increased sensitivity of the of the nerve endings in the myometrium. Resulting in dysmenorrhea. See, this chart shows the same thing actually. So, how to diagnose dysmenorrhea? It is the detailed medical history, which can differentiate either the woman suffers from primary or secondary dysmenorrhea, and a thorough physical examination to rule out any other pelvic pathology. There is no any pelvic pathology. It is termed as primary dysmenorrhea. So let us come to the treatment. As you all say, the mainstay of the treatment till now it is all us NSIDs. So that stays with the first line of therapy. As a gynecologist, we use a lot of mefenic acid, the most commonly used. The second line of treatment is oral contraceptive pills, especially in ovulated bleeding, we can use that. So there are a lot of NSIDs available in the market. As you all know, we use according to the woman's thing, but they are not gastri friendly. They have a lot of side effects also. So like diclofenac can be used in various dosages, like indomethacin, naproxen sodium, piroxicam, all these can be used in the various dosage forms. So the management of primary dysmenorrhea depends upon medical management, is divided into non-hormonal and hormonal. As I said, the non-hormonal mainstay is NSIDs, the various preparations we can use. The hormonal, the mainstay of the hormonal are combined oral contraceptive pills, only progesterone containing IUCDs, that is intrauterine contraceptive devices like Mefena coils, which has levonorgestrel, which is used in pain due to adenomyosis, like that. It relieves the pain in such cases. It releases the progesterone sequentially, so thereby the adenomyotic dysmenorrhea is addressed. The mechanism, I do not want to go into very detail because this is a boring slide. The mechanism of action of the prostaglandins, there is because the prostaglandins is present in the arachidonic acid present in the cell membranes, the lipid. So once it is activated by phospholipase, it secretes lipoxygenase and coxygenase, that COX1 and COX2. They produce the endoperoxidase and they produce the various prostaglandins like this: prostacyclin, prostaglandin E2, and thromboxane. As you all know, prostacyclin, their action is causes platelet aggregation and vasodilation and decrease uterine tone. While the prostaglandin E2, like misoprostol, we have, one of the action they act like they increase the uterine tone, and the contractibility increases the vascular tone also, and also produces increase in the temperature. So hence only it is used as nowadays it is used as a medical termination of pregnancy to expel the fetus which is there, because of the prostaglandin E2 effect. And also, as you all know, thromboxane A2 has it causes vasoconstriction and platelet aggregation. So what are the drawbacks of NSIDs and OC? Because as you all know, there is a lot of gastrointestinal side effects. It cannot be given in APD, like people having gastrointestinal bleeding, or it cannot be given. A patient who have migraine dizziness, even in that, the OCPs cannot be given. So some patients may have hypersensitivity or allergic reactions, and it cannot be given in a woman with such things. So the overall failure rate of this is 20 to 25%. So long-term usage is always discouraged because of the associated side effects. So oral contrast pills are not approved by the FDA for dysmenorrhea, because, as you know, it causes thromboembolic phenomena. Long-time usage can make precipitate DVT, or stroke also in perimenopausal women. So let us go to what are the other approaches for dysmenorrhea. As you all know, there is acupressure, heating pads for cramps. So there is separate beds also. sleep therapy, physical exercises, meditation. Some medicinal herbs are there used for, like ginger root, turmeric, curcumin, that is pineapple extract, fennel extract, rosemary, and some of the medications like uh, calcium and vitamin D3 supplementation. So, what are the investigation to be done in a primary dysmenorrhea? As we all do, full blood count had to be ruled out, whether they have any infections like PID or pelvic inflammatory disease or pelvic genitourinary infections to rule out, the CRPs to rule out also. And you have to take high vaginal swab, endometrial swabs also to endocervical swabs also to exclude infections like chlamydia trachomatis and gonococcal infections. CA125 to rule out endometrial, but it's non-specific because CA125 is not specific to endometriosis or endometrial cancer. It can be raised in any inflammatory conditions. It is a prognostic factor in a ovarian cancer. So it is also not a specific marker. So we as a standard, we do in severe or moderate dysmenorrhea women approaches, we do an ultrasonograph of the abdomen and the pelvis to rule out any uterine anomalies like Mullerian anomalies like cryptomenorrhea, to rule out cryptomenorrhea and hymen anomalies, the outflow to uterine tract anomalies, which may cause precipitate dysmenorrhea, acid dysmenorrhea, and also to rule out tuber-ovarian abscess or endometriosis. Now, recently, the hysteroscopy is added on into the diagnostic armamentarium to delineate endometrial polyps from submucous fibers. Finally, once all of the methods are failed, we have to use a diagnostic laparoscopy to diagnose minimal endometriosis or any pelvic condition or early PID in those women who have severe dysmenorrhea. So this it is also, there are a lot of over-the-counter prostaglandin inhibitors, as I said, aspirin, ibuprofen, naproxen sodium, mefenamic acid also. So as I said, the oral contraceptives can be used in the ovulatory women who suffer from dysmenorrhea. But it takes care because it acts by stopping the ovulation. So the ovulatory cycle becomes anovulatory. In that way, it acts as a anti-dysmenoric medicines. So Depo-Provera also is used to decrease the prostaglandin levels. As I said, this slide also, it increases ovulation, so thereby decreasing the prostaglandin secretion, and it also decreases the endometrial thickness. So on the whole, it decreases the ovulation. So the woman will have an ovulatory cycle, will not painless menstruation. If all these measure fails, there are methods like cervical dilatation and pre-sacral neurectomy. Follow this method failed. Pre-sacral neurectomy is a surgical removal of the pre-sacral plexus of nerves that connects the pain from the uterus to the brain. So it is indicated in the treatment of central pelvic pain, including severe dysmenorrhea. What else may be helpful to improve the dysmenorrhea? To continue the normal attitude, gentle abdominal massage, regular exercise, avoid stress, avoid lack of sleep, avoid spicy foods. These are the measures. So this is a chart which differentiates primary and secondary dysmenorrhea. By taking a detailed history, we can differentiate which is primary, whether the patient is suffering from primary dysmenorrhea or secondary dysmenorrhea. And this chart shows the same thing. So dysmenorrhea should not be confused with premenstrual syndrome, which presents with similar symptoms. It is a separate entity which resolves shortly after menstrual flow has begun, because unlike dysmenorrhea, which continues during the menstrual cycle periods, that is 1 to 3 days. But premenstrual syndrome is a progesterone effect, actually. That is a progesterone effect, actually. It starts before the periods. It culminates once the onset of periods starts. The premenstrual syndromes or symptoms will disappear. So it's a group of physical and emotional and behavioral symptoms that occurs in the second after, that is the luteal phase of the menstrual cycle. Often it interferes with the work and day-to-day activities, and there is a period of symptoms entirely free starting from that. That is the follicular phase. The woman will be free from the pain. Only in the luteal phase, on the second half of the thing, a prayer 1 week prior to the menstruation, these symptoms appear again. As you all know, there are a lot of symptoms like bloating, feeling of weight gain, edema, breast pain, tenderness, hot flushes, mood changes. They'll have pelvic pain, change in the bowel movements, either the diarrhea or constipation, associated pain in the muscles. Mostly, I said the mood changes, there'll be irritable aggression. Some may go for depression also. What is the cause? Not many known theories, various hormonal interactions. One of the theories is also vitamin B6 deficiency and psychological. Most of the theory is based on the luteal phase progesterone effect. So ovulation and progesterone production are more important in these syndromes. The drugs that inhibit ovulation release the PMS symptoms. So what is the management of PMS? The thing is counseling and reassurance that the symptoms are real and it could be treated by changing lifestyle modification, exercise and dietary modifications. So we can advise the patients to exercise frequently, which increases the endorphins in the brain, distracts the woman from the emotions. Regarding the medical support, we can give diuretics, anti-prostaglandins for them, like mefenamic acid, like or diclofenac or paroxetine, so to relieve the cramps. And to relieve the breast tenderness, patient can be given bromocriptine or B6 also. So to really ovulation suppression can be done by either OCPs or danazole or medroxyprogesterone, DCA can be given. Or nowadays, the newer drug also, Primrosa along with B6 is coming along with tocoferols. That is vitamin E also is used in this PMS. And it's a combination therapy. It can be given to the patient in the luteal phase 10 days before the periods to relieve the symptoms of PMS. So this slide shows the management pathway of the dysmenorrhea. To rule, we have to get a proper history. There's no pelvic pathology associated. We have to address it various methods, non-pharmacological or pharmacological. If there is any pelvic pathology that is called a secondary dysmenorrhea, according to me, we have to, when there is a secondary pathology, we have to refer to the gynecologist or to the specialist who deals with them. So let us come into the newer mode of treatment for primary dysmenorrhea. There are a lot of herbal extracts. So I'm going to just give a short talk about how the herbal extracts helpful in the treatment of primary dysmenorrhea. What are the mode of action? So one of the molecule is a bromelain, which is derived from the pineapple extract. It has PGE1 and PGI2. PG1, E1 and PG12 or anti-inflammatory, and also has prostaglandin E2 and prostaglandin F2 alpha and thromboxane A2, which are pro-inflammatory prostaglandins. As I said, previous slide itself, I said this bromelain acts in the PGI, GI and E2 also. So thereby it reduces the production of endoperoxidases. So inhibiting the arachidonic acid cascade actually. So the analgesic effect is also produced by decreased uterine antispasmolytic. That is, it decreases the uterine contractions. So it and also bromelain also acts by modulating the tumor necrosis factor alpha and interleukins, various interleukins. On the next product, herbal product is rosemary extract, which is the active ingredient is ursolic acid. It is the active ingredient. It is a food product actually. So bromelain is used. The study bromelain is given in primary dysmenorrhea. That is a study done in an international journal. That is 39 female students are registered in this. In the age group of 15 to 17 years enrolled. They gave pineapple juice, which has bromelain and a placebo. For the primary dysmenorrhea patient, that is only for 1 to 3 days of the cycle, 3 cycle. The pain score was noted, and it was compared. So the pain score before the treatment was 5.24, and after the treatment, there is a 50% reduction in the pain score. Coming to the next product, rosemary extract, which has the Ursolic acid, which is a COX-2 inhibitor. Rosemary, it inhibits the cyclooxygenase 2 enzymes, which reduces the production of the prostaglandin. So mefenic acid also has a similar mode of action as the rosemary acid, which also, so they act as an antispasmodic and analgesic action. So it also can reduce, rosemary extract also reduces the production of interleukin beta and tumor necrosis factor alpha and has an anti-inflammatory effect. So this is the mode of action of rosemary extract. It acts on the arachidonic acid pathway, reduction in the prostaglandin synthesis, thereby reducing the dysmenorrheic pain, any pain. So this is a study done by comparing the Ursolic acid versus mefenamic acid. 82 women taken into the study around the 18 to 20, that is the adolescent period, 18 to 25 years of age women are enrolled in this. They are divided into two groups using Ursolic acid, another one giving 250 milligram Ursolic, and another group has taken 250 milligrams in the first 3 days. Once again, the pain score was measured, and the conclusion was Ursolic acid was effective as mefenamic acid. The next product is curcumin. As you all know, curcumin is known as it's a manjal, no? Like it is from the Curcumina longata, and as curcuminoids such as curcumin, D-methoxycurcumin, and this methoxycurcumin. It's a member of some regional. So as you all, it's a food product actually. It is used in the various Indian and Asian cuisines. So how does it act? It acts by modulating the inflammatory response by regulating the cycle of COX-2 and lipoxygenase and nitric oxygenase enzymes, which can reduce the pain, so that it will reduce or even inhibit uterine contraction. The mechanism of action of uterine contractions by curcumin is by reducing it inhibits the inflow of calcium ions, that is decreasing the cyclic AMP into the myometrium. So thereby the calcium influx is aborted. Thereby it decreases the cyclic activation of the myometrial cells for contraction, decreasing the cyclic AMP. Thereby the pain is relieved. So it also has anti-inflammatory action. So curcumin is frequently used with bromelain to improve absorption of all our meals also. So this is the mode of action, this slide. Same thing, it stimulates, it inhibits the prostaglandin synthesis. So this is a study done in 32 young women with primary dysmenorrhea. Women were divided into two groups. One set of women had a curcumin homemade drink. Another drink is given by the researchers. So all these women had these two types of drinks for first 3 days of the menstruation for 3 months. So this pain studies was done, and it is the final thing. So there is significant reduction of dysmenorrheic pain by curcumin drink. Next to the herbal products is Fenchone and anathenia. So this is also a food product where it is where does the Fenchone and ethanol comes from. So what is the mode of action? This is a mode of phenol. The mode of action of phenol extract is similar to diclofenac. Fenchone is the main component of phenol that inhibits prostaglandin E2 and reduce uterine contractions. It is an anti-spasmodic. Anethole is the main components of phenol and has a similar structure to dopamine, which binds to dopamine receptors and thereby decreases the pain analgesic effect. The anti-inflammatory action of phenol is due to inhibition of histamine, H1 and H2 receptors. So this is a slide which shows the action of Fenchone, that is the phenol extract. It also acts on the arachidonic acid on the cell membrane by producing various prostaglandins, and also finally it stimulates the endoperoxidase, like endoperoxidase 2, 4, and 3 and 1. Thereby it inhibits the influx of calcium into the cell membrane and decreases the cyclic AMP. So what is the effectiveness of Fenchone versus mefenamic acid? 100% of women had pain before starting of the treatment. The woman received either Fenchone or mefenamic acid in this study. So out of this, the woman, 80% of women were, 80% of women, the pain was decreased compared to mefenamic acid, which was only 73%. So Fenchone is as effective as mefenamic acid. So there are a lot of herbal preparations now available in the thing, like a combination of herbal preparation like curcumin, bromelain, fenchone, phenyl extract. These molecules can be used in cases of primary women coming with moderate to severe primary dysmenorrhea, because these herbal products are less of side effects. Like NSAIDs and OCP pills cannot be given to all the patients for longer time of these herbal products, which are all from our kitchen actually from our food products. So it can be used for a longer duration, and safely also it can be prescribed. So what is the take-home message? So this take-home message is dysmenorrhea is found it's highly prevalent. It's one of the most common gynecological complaint seen in the woman in the reproductive age group. So findings suggest a lot of findings suggest there is a family history. The bleeding duration also differs. Presence of clots acts as a significant factor for dysmenorrhea. There should be appropriate intervention through a lifestyle changes in the diet and then. So there are the barriers to seek medical attention by the dysmenorrheic females need exploration. So we have to teach the female about the menstrual hygiene, reproductive tract hygiene. That stays the main thing, because most of the primary or secondary dysmenorrhea is main because of their unawareness, and they take a lot of doing adolescent training. We can approach these women when they suffer from these type of pain or thing. We can give them good advice, and also we can inculcate in these good behavior, reproductive behavior, genital tract hygiene, and reproductive behavior. I thank the Shield Connect people, and also the listeners, for the patient listeners of the doctors. I thank you once again for the patient listening. Thank you, sir.
Thank you, ma'am. Thank you very much for that wonderful and detailed presentation. Yes, ma'am. This is one of the most important topic which is mostly ignored by the.
Yes, most of the day, because this is one of the more topic. No, it's a condition mostly it is addressed by the over-the-counter medications.
Yes,
Because we have to rule out whether the woman is adolescent woman's reproductive woman is having primary or secondary dysmenorrhea. Without doing the investigation or detailed history, we cannot delineate the patient either they suffer functional, that is primary, whether they are secondary. Because secondary dysmenorrhea, the treatment itself differs according to the causes of secondary dysmenorrhea. It can be either medically treatment, or it has to be treated surgically on that. So, so the creating awareness in the reproductive age, especially in the school girls, adolescent school girls, teaching about menstrual hygiene, what is dysmenorrhea, what is the menstrual cycle, what is unwanted pregnancies. These all should be addressed in a larger manner, especially by doing school health programs. I think in that way, it will help them in a longer way. Thank you, sir. Any questions regarding?
Yes, ma'am. Let me wait for 1 or 2 minutes for the participants to post their queries. If there is any
Yes.
query, then I'll lead it for you, ma'am. Ma'am, and I'd also like to request you to address the risk factors of self-medication, ma'am. Because these adolescent girls, school-going and college-going girls nowadays, they are self-medicating for this primary dysmenorrhea, ma'am. I request you to address on the risk factors behind this, ma'am.
Yeah, most of the now, actually, when I started my practice 34 years back, it was one of the most commonest causes coming into the OP, kind of OP or any general practitioner women's OP. But nowadays, we don't see that such women's school girls or adolescent girls coming for dysmenorrhea because on the over-the-counter medications are available. So they go, they take from the mother's thing, next neighbors medication they take. Thirdly, they go to the medical shop. They buy some medications for temporary relief. Without knowing whether they are suffering from secondary or
Yes.
primary dysmenorrhea. As I said, secondary causes treatment itself, the mode of treatment itself, it's different. If primary, we can treat it. As I said, the primary, it's because of the ovulation, actually, adolescent women. So we can, once you give a ovulation OCP pills, stopping the ovulation, the treatment works. So as I said, they use a lot of NSAIDs without knowing the long-term side effects. So it can be addressed by going to the school adolescent training, teaching programs. Initially in Foxy, we were doing a lot of adolescent training programs. But nowadays, there is, I think these girls are always behind the studies, actually,
Yes.
getting marks instead of taking the healthcare, actually. So they ignore these symptoms and they go for the wrong medications. So
Yes.
I will advise you people all to put in word to the government to once again to start adolescent school teaching program. We
Like
as a
awareness
Foxy
programs.
people, as
Yes.
a gynecologist, we are ready to go and teach them. But some of the CEOs of the schools, particular districts, all they don't allow us to go to teach about menstrual hygiene, reproductive tract infections, and what are the high risk behavior of the girls. So I think we, as a pharma people, as a doctors, also we all should join and because you, as you see in the media, it is too. It's these problems are too much exaggerated, and it should be addressed to these women, girls, and we should help them to come out of these problems
Yes.
by addressing them in the schools.
Yes. Ma'am, we have one question, ma'am. Whether this dysmenorrhea will affect infertility in future, ma'am, if untreated?
No, dysmenorrhea primary will not do anything, no harm. Only the secondary, as you said, no, the secondary can be some endometrial polyps can be there, some uterine anomalies also that also some patient recently had one patient, 30 years old lady. She was a primary infertility for more than 6 years. Once we did investigated, she had a myometrial polyp, intramural polyp actually, so which was distorting the endometrial cavity. So she cannot become pregnant. That could be one of the cause because the endometrial receptivity is at the thing, and it is at the thing. So we did a laparoscopic myomectomy in that case. So in that way also the secondary dysmenorrhea, the primary dysmenorrhea will not produce. Primary dysmenorrhea will have once the woman has what is the fear for sex, actually. So in that case, because of the pain, the woman, young adolescent woman will not have proper sex. In that case, they can have infertility. But also such, it will not produce infertility in primary. Secondary dysmenorrhea has a lot of, like I said, endometriosis. That is one of the main causes for infertility. PID also, especially genital tuberculosis, they are irreversible damages. PID and severe endometriosis, they produce irreversible damage to the oocytes and also the endometrium and to the adjacent structure that may cause secondary infertility. There is a cause for subfertility, and they are the candidates for the oocyte donation or IVF. That way, it will affect the fertility of the woman.
Thank you, ma'am. Thank you very much for that detailed and wonderful explanation, ma'am. Ma'am, we don't have any questions in the chat box, ma'am. So, ma'am,
Thank
if
you,
you
sir.
allow us, then we can end the webinar for today, ma'am.
Thank you for giving me the opportunity. Thank you, Sri Ganesh.
Thank you, ma'am. Thank you very much for being with us and spending a valuable time with us. And we once again thank you for being with us. And ma'am, we are looking for many more informative webinars like this topic, ma'am. Many more social awareness webinars for the common public also, ma'am. Thank you, ma'am, and thank you once again, my team, Dr. Mr. Nainan sir, for arranging
Thank
such
you,
a
ma'am.
wonderful webinar, ma'am.
Thank you so much.
Thank you, sir. Thank you. I think I done it a little bit. Okay,
Thank you.
okay. Thank you.
Thank you,
Thank you,
ma'am.
ma'am. Thank you very
Bye,
much.
ma'am. Thank you, sir.
Bye, sir. Bye, sir.
Thank you.